But yeah, I don't really think drugs are dumb. I just think sometimes the things we do with drugs in cardiac arrest are a little bit dumb and maybe don't make a lot of sense for what it is we're treating. And largely that's because we try to make everything simple and like, yeah, protocolize this stuff or put this in an algorithm. Remember, so follow your algorithms. Oh my, yeah, okay. Again, algorithms are fine in a way to kind of keep you on track. And they're pretty good for a doctor's office who doesn't do resuscitations a lot. Yeah, pull that card out, start looking at it, go ahead, man. But if you're a professional rescuer, if you do this all the time, if this is your job, you kind of got to have that next step. So you should at least know about the drugs that we are pumping into people. And a lot of times, unfortunately, the no part means that I don't see the point in giving a lot of this anymore. And of course, if you give it in the wrong way, then you potentially poison somebody because everything is poison. Let's talk about the drugs real quick. This is the ACLS drugs. We'll go through a quick thing here. I'll do as fast as I can. Ready? Here comes epinephrine. Epinephrine, what's the idea behind epinephrine? Epinephrine hits essentially all of your adrenergic receptors, the alphas, the betas, all that kind of stuff. What does it do? Well, it's an inotrope, it's a chronotrope, it's a vasopressor. It makes your heart beat a bit harder, it makes your heart beat a bit faster, and it causes some vasoconstriction at the doses, especially the doses that we give. The idea being that when you have more stuff being put out by the heart because of the harder and the faster squeeze, and then the tighter vasculature, that your blood pressure goes up, and then you can perfuse things better because you're reaching more. And of course, the idea, if you're in cardiac arrest, maybe if your heart's just kind of sitting there doing that, you can get a little bit of extra stuff with it. But the big thing is that vasoconstriction. While you can kind of flog the heart with it, if the heart is mostly dead, it just can't really, it can't really go anywhere until it gets good perfusion back anyway. If you give somebody epi while you're doing chest compressions, the smaller volume, the vasoconstriction, raises by a little bit the blood pressure that is generated, and maybe you can perfuse the heart more and make it work a little bit better. But it, in and of itself, just giving an epinephrine without the rest of the stuff doesn't really help you. Unfortunately, epinephrine has not really ever been shown to have a good, really change the way that people survive afterwards. Now, a couple of studies on it. The original study was basically they intubated some dogs. They put their thumb over the end of the ET tube until the dog asphyxiated, and then went into cardiac arrest, and then they tried doing intracardiac epi versus some other things. And this is like 6 dogs that got intracardiac epi, and some of them did a little bit better and had more ROSC than the other dogs did. And so they said, oh, this is a great thing. We got to start giving epinephrine. And that's essentially the basis of where we got epi in cardiac arrest. Okay. It took till 2000. This was like 1960 some odd, I think. It took till 2011 to actually have the first placebo-controlled randomized trial for cardiac arrest, epinephrine. And what they found was basically the same thing that every other study that's looked at epi has seen, was that it seems to be more ROSC. This is survival over here. More ROSC with epi than compared to placebo. But survival to discharge and neurologically intact survival, good survival, meaningful survival did not change. There were some flaws with this study just in the way that it actually got performed. And so there's been some other ones that also show similar things. If you give epi early in a shockable rhythm, it's associated with bad outcomes overall or worse outcomes overall. And then there was the Perkins study, the Paramedic 2 group that looked at it most recently. And again, did a good randomized trial of epi versus placebo, and produced a graph that looks something like this. And I'm not a research nerd mostly. I can just kind of interpret things a little bit. Basically, here's this graph of neurological outcomes. There's a lot of different colors, so I'll bust it down. Here is in the placebo group, the orange is the good outcome, the blue is the bad outcome, the patients with it. And then in the epinephrine group, the orange is the good outcome, the blue is the bad outcome. You see that they're pretty much the same. Maybe there's a little bit more bad outcome in the epi group, actually, at least a little bit of trend to it. Now, there's a good chance that a lot of what you get here is that the patient survives a little longer. They do get more ROSC, but unfortunately, at the end of the day, they just get enough ROSC to survive to die in the ICU later because their brain never comes back online. So there's not great data to show that epi actually makes a difference. beyond getting them to the hospital itself. Now, maybe getting them to the hospital itself with a pulse is what you really want, but for the most part, we mostly say, that's probably not it. Epi's still out there. I'm not telling you not to do epi. Epi is still the quote-unquote standard of care, but you would have thought by now that we would have definitely leaned back towards like, let's space that out, let's de-emphasize it a bit, let's do other stuff. And to some extent we sort of are, but what does everybody do? They're really happy about the amount of epi that they gave. We gave epi every 3 minutes. To what end is, of course, the question. Just to keep in mind, epi does increase ROSC. There's not been evidence so far to say that it actually increases survival at the end of the day. Again, don't give epi. Talk to your medical director. Follow your local protocols. Bicarb. You'll hear that all the time. I gave 3 rounds of epi and 2 amps of bicarb. Okay, what's bicarb really supposed to do? You have acids and bases. Bicarb's a base. Bicarb is essentially baking soda. And if your body gets a little bit acidic, like vinegar in this case, and you mix them together, the acid and the base react, and you generate carbon dioxide per this equation. And this goes on in your body. This is what happens. You have acid over here, throw in some base with it, and that pushes everything the other direction, if you remember high school chemistry, and you push out CO2. And you would think in somebody that's really acidotic, because they've been in a rest for 30 minutes, oh man, give them a couple of amps of bicarb, see if you can't get that acidosis to get better, their heart will work better, that kind of stuff. Unfortunately, you just don't really see that happening. Number one, the amount of bicarb that we give doesn't really buffer that much. It doesn't really improve pH much at all. And a large part of that is that in this system here, the foaming vinegar and baking soda, the carbon dioxide can escape so that hydrogen ion can go someplace in the form of water. In your body, the carbon dioxide escapes through your lungs, and in cardiac arrest, you're not really able to blow off that carbon dioxide anyway. So it's really not an effective means of buffering anything. But nonetheless, theoretically, should it work? Not really, but does it actually work in practice when we give it? Not really. Here's a study. The green is folks that did not get bicarb. The blue is folks that did get bicarb. Does giving it in severe acidosis after prolonged arrest actually makes a difference? No, it's no significant difference between any of them, but you actually find, if you look at it, the green side, the side that is not bicarb, actually did a little better on all those than did the guys that did get bicarb. Taken in that case, there was no true statistical significance, so you can't say that it actually was a real thing. In this one, there is a statistically significant difference. This is what happens when you give bicarb and out of hospital cardiac arrest. Do people survive more? No, these folks did not survive to discharge more when they got bicarb. They survived more when they did not get bicarb, and they did not have better neurological outcomes. Now, it's an association. It's not to say that the bicarb necessarily did it, but there's a lot that goes on, and it's either that we're using bicarb wrong or the bicarb's doing something that's making us not helpful. So again, correlation, not causation necessarily, but folks that got bicarb did a lot worse than folks that didn't get bicarb and out of hospital cardiac arrest. So bicarb's almost never the answer. Don't give bicarb. It's almost never the answer unless there's something really specific like a TCA overdose that you're treating. How about amiodarone, everybody's favorite antiarrhythmic, everybody's very expensive antiarrhythmic? How does it work? Mostly it makes your heart cells harder to repolarize. It takes the amount of reset time that your cardiac myocytes need and stretches it out, so that if another fibrillation current hits it in the meantime, it just bounces off. Your heart cells say, nope, not ready to fire again anyway, sorry. And theoretically, if you get enough cells to do that, your heart could go back. You could break that fibrillating rhythm. You could go back to a normal sinus type rhythm, or at least an organized rhythm in the way that we want. Makes sense. Amiodarone's not a bad antiarrhythmic. It's just not a good cardiac arrest antiarrhythmic. The way that we got amiodarone was that they showed that amiodarone is good at breaking it's good at breaking the fibrillation. It's good at breaking the dysrhythmia. But it doesn't mean that you survive more. In fact, it's never been shown to have an actual survival benefit, just that the VF ends faster with amiodarone. Unfortunately, sometimes that VF then goes into an agonal PEA or an asystole. And that's technically success. You did technically stop the fibrillation, but you didn't help the patient. The most recent study on that one is the amiodarone versus lidocaine versus placebo, and in this one there's, again, not a statistically significant difference. I suppose that's not to be that they are absolutely the same, but there's not a really big difference between whether the patient got lidocaine, whether they got amiodarone, or whether they got placebo in terms of their survival to discharge and their neurologically intact survival. And this kind of just says what I said. All right, how about naloxone? Let me take a second and say naloxone has no place in cardiac arrest. Why? Everybody likes naloxone. Everybody knows naloxone. Everybody gives naloxone. Police seem to really like naloxone. Bystanders, if they have it, seem to like naloxone. Good for the goose, good for the gander. Why wouldn't you give it in cardiac arrest, especially if you think it might be an overdose? Well, here's the thing. You die from an overdose in sort of a circuitous thing. It's not like you get a dose of heroin and it's just too much and 2 minutes later you're dead. That's just not what happens. You have to follow this pathway of you overdose, you get CNS depression, then you get respiratory depression, and you get some hypoxia from it, but you also get really hypercapnic. And once you get hypercapnic, you develop CO2 narcosis, and you lose your ability to self-rescue, and you get more hypercapnic, and eventually you get acidotic. And a combination of acidosis and hypoxia eventually leads you to cardiac arrest. Now, naloxone works on stopping this respiratory depression, or decreasing the CNS and respiratory depression. That's essentially what naloxone does to stop you from dying of an overdose. The problem is, if you're already in cardiac arrest, the respiratory depression at that point is going to be due to the cardiac arrest and not to the overdose anymore. You're not going to breathe because you're dead, not necessarily because you have too much opiate on board. And you're already fixing the respiratory depression when you bag the patient and when you manage their airway. So giving them medicine that maybe improves their respiratory depression does not really help you, because you've already, number one, fixed all the stuff, and number two, that's no longer the reason that they're having trouble breathing. They're now having trouble breathing because their heart's not beating effectively. So there's no good reason to give naloxone in cardiac arrest. And you may say, well, is it going to hurt anything? Well, it's a medication that doesn't have a reason for giving it, so really it's not ethical to give it if you're not going to change anything with it. But also, when you look at people that did get it, this is a small study, small numbers, I understand that, but when you look at their actual outcomes, after folks got a dose of naloxone, at least half the time, their cardiac rhythm didn't change, and most of the time after they did have a change, their rhythm went worse, meaning they went from like a faster PEA to a slow PEA or to an asystole. So most of the time it didn't seem to make any difference, and of the ones where things actually did change, things got worse as a result, generally speaking. So don't give naloxone in cardiac arrest. If you're bagging them, you have fixed the thing that naloxone would have fixed. Glucose. Should we give empiric glucose? We need glucose to make ATP because of this. And that's all I'll kind of say about the background of it. So maybe we don't, everybody needs sugar, so giving them a little extra sugar, because maybe that was what made it. Maybe they were just so low that they died as a result. What you find is that's generally not the case. It's almost never the glucose that's the problem, and fixing the glucose in itself doesn't, at that point, really fix a whole awful lot. Maybe if their glucose is 5 or something like that, yeah, they could use some sugar and try to fix that up. But generally speaking, if you're treating a glucose of 70 with a bunch of dextrose like D50, that's probably not what made him arrest to start off with. And it just goes that if you're giving people empiric glucose, their outcomes are not as good. And they sort of live long enough to wither in the ICU, sort of the same as when you give them epi. They might get to the ICU more. They have worse outcomes once they get to the ICU. Okay, so don't give empiric glucose. Again, you want to treat a glucose of 5 or of 10 with an AMP D50. Okay, knock yourself out. I can buy that. don't give glucose of, don't worry about giving them empiric glucose if their glucose is 59. That wasn't the problem. Focus on the other stuff. Fix the other stuff. And then if you get them back, you can fix their slightly low glucose at that point. How about calcium and magnesium, the other two drugs that we hear people give sometimes? In the ACLS stuff, it says not recommended for routine use. Realistically, all these drugs shouldn't be really recommended for routine use. You should be treating something specifically. And you don't say, oh, I'm using it to treat cardiac arrest. That doesn't really count. What are you treating in cardiac arrest? Why you want to give this stuff? But there is actually good stuff that you can do with calcium and to some extent magnesium. There's these unless things. So I will not poo-poo these as much as I poo-poo everything else, but it shouldn't go to every patient. For instance, if your potassium is high, your EKG strip goes something like this. It starts off, the T waves get taller, the QRS gets wider, and it starts to look more and more like that sine wave, and then you eventually get either essentially agonal PEA or VF, and the person dies at that point. However, if you give somebody with an elevated potassium that's EKG is changing it like this, if you give them calcium, a couple amps, 2-3 amps of it, and their EKG goes back down and starts looking like that again. And that is a helpful thing. Now, it doesn't last very long. It buys you just enough time to kind of get the patient someplace where they can get that potassium taken off. But calcium in these folks does work to help stabilize the membranes, and it is an effective treatment. So in that case, if it is potassium that you think you are treating for whatever reason, calcium is absolutely indicated, and you can give somebody with a potassium of 9 all the epi you want, but they won't get better. You give them 2-3 amps of calcium, 2-3 grams of calcium, and a lot of times you actually get ROSC back on them. So do bear that in mind. Don't be afraid to give it if you need to give it, but don't just give it to somebody. Oh, there's an off chance that he's developed new renal failure. That's not the right move. And then how about magnesium? You see here the polymorphic ventricular tachycardia, the dreaded Torsades des Pointes. I know that's not how you pronounce it. It's fine. You are told to give them magnesium. By the time, or I think that most of the time we actually misidentify torsades. We just see like a polymorphic VTAC, or usually it's a coarse VF. We're like, oh, let's give them some magnesium. That's clearly torsades. It's almost never torsades, but maybe sometimes you see something like this. The interesting thing about giving magnesium is that the true treatment if they don't have a pulse with their ventricular tachycardia, the true treatment is to shock them. But the magnesium helps prevent going back or going into torsades to start off with. So usually torsades, at least as it kind of starts, will be these fits and spurts of ventricular tachycardia. But a lot of times you'll be able to break it, or the patient will still have a pulse, and you give them magnesium and it stops it, and that's better. Once they go into cardiac arrest, the real thing that fixes it is electricity generally, and then the magnesium helps to keep them from going back into it later on, helps to actually treat it. A little bit like amiodarone in that way. But remember, it doesn't really stop it. It just prevents it from coming back. So should you give it to every person who's got, a shockable rhythm? No. Focus on doing CPR. Focus on doing some reasonable ventilation and doing all the other things, and the electrical therapy and the lack of pauses and that kind of stuff. So on the sum up here, drugs aren't actually that dumb. They just get kind of used in dumb ways sometimes. And they're usually not the most important thing. If you have something that you are specifically treating, drugs can actually be super, 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 super helpful, and the patient will come back kind of right away. Some epi is probably helpful sometimes. A milligram of epi every 3 minutes to a patient who's in persistent VTAC is probably not the right move, generally speaking. Amiodarone maybe is helpful. It does seem at least to stop you from making squiggly lines on the EKG tracing, but doesn't guarantee that you're going to survive. If you want to give it, give it. Bicarb, and this is just an FYI, bicarb is probably not helpful. Bicarb, as I say, bicarb is never the answer, unless like the one time when it is the answer, but otherwise bicarb is never the answer. Naloxone is never the answer. If you are doing chest compressions, you should have a bag out, and you're fixing the respiratory depression with that bag. calcium definitely is the answer in the right person. But in most people, it's probably not very helpful. All right, that's the ACLS drugs. That's the background on them. Hopefully it was a little bit helpful.